Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Well, today we're fortunate to have internationally renowned surgeon, Dr. Louis Ivey, who has been honored in so many different ways. It's hard to capture all of the things he's done in his long career. He probably is mostly noted as a Penn State graduate. He's one of the really black graduates, and a founding member of the Kappa Alpha Psi fraternity there. He's many firsts, and he was the first black officer from their program. And it's interesting because he also majored in German as well. And that seems to be appropriate because he wound up in his duty in Germany. And so it's interesting, he was well fitted for what followed. The service in the service in the, I guess, in the Navy, I guess you call it. He served on the USS New Jersey, and he was known not only to be the first black officer, but also has been called back to duty. He is also duly known because because he was the first black officer. He actually has a voucher which has an annual award in his name. Uh, he is retired from the Navy as captain. That's just talking about his military career. And we haven't even talked yet about his surgical career because he was trained by the great C. Walter Lillehei in New York and was actually the first black surgeon to be trained in open heart surgery. And actually did special training in Milwaukee under the pioneer Bentley Johnson. Came back and then actually did the first coronary artery surgery at Howard University. He doesn't mention this, but he also actually started the ICU at Howard University. But what is interesting is that in addition to all of this, he also was chairman of the government service hospital. And then in 1988, he decided to take a different uh, career choice, and he decided to specialize in vascular surgery, particularly the treatment of venous diseases. And that's why today he's going to talk about something that he's internationally renowned for. Since 1988, he's devoted his practice solely to the treatment of venous disease, with varicose veins, stasis ulcers, and other complications of untreated varicose veins. He's internationally renowned, traveled all over the world teaching about this, and so we're very fortunate to have him to talk to us about an area that he is non-paral, an area that no one can talk about more than he. And so thank you very much, Dr. Ivey, for agreeing to talk to us about the many issues related to varicose veins and the treatment of venous diseases.
Thank you very much, Dr. Callender, for inviting me. I'm indeed honored to join you for the third time, but to speak for the first time. So I had planned to spend part of this morning talking about you, but I'll save that for another day.
Good. They know enough about me.
But can I share this screen? Carol?
Yes, I guess. What do I have to do?
John told me that I could share it. So
Okay, yeah,
I'll
sure.
just click share it.
Okay.
Okay, there we go. Wait. I did something wrong. Now, I can't get back to my screen. Oh. Oh my. This is illiteracy on my part here, how to work this computer.
Dr. Ivey, once you click the share screen at the bottom,
Uh-huh.
then you go to the program you want to share and click that on your desktop. And it should come up.
Okay.
There you go.
There we go. Now, just takes it.
I'm still a teacher.
Well, today's subject is venous insufficiency. And venous insufficiency is a very broad topic because it concerns the veins of the body, and all the arteries in the body end up in touch with the veins through the capillaries. So it starts from the head to the toe. It's all inclusive. However, varicose veins happens to be the major source of venous insufficiency. And the venous insufficiency is basically because of the failure on the part of the veins to perform as they were physiologically designed to do. That is, bring the blood back to the heart, both from the foot, the ends of the fingers, and from the head. All of the blood returns to the heart through the veins and empties into the veins, where it's refreshed and then recirculated from the heart in the arteries. So that covers a lot of territory. The major problem associated with venous insufficiency happens to be varicose veins. And varicose veins, I would say over 80 million people in the US suffer from that. That's 1/4 of the population being somewhere near 330 million people. So you can see it's pretty extensive. And the question is, why do we have varicose veins? Who has varicose veins? How do we treat them? And how do we classify them? All of those questions I'll try to answer when we start off here. First off, veins they come in different sizes. Very small ones, which we call spider veins or telangiectasia. And these are primarily related to the estrogen hormone. Women have these primarily in the lateral thigh. They are not associated with varicose veins. And both men and women have estrogen and testosterone. Some people feel that the presence of these veins is a reflection of the sensitivity of the particular person to the hormone. And because these veins appear in women more than men in this sort of a rainbow pattern around the lateral thigh, it's associated with the estrogen factor. Now, this is not to say that only women have these, but these are veins that most men don't complain of. And I have seen perhaps one, at most two, in my 50 years of working with the venous system in males. These are not, pardon me, going to go beyond where they are now. They may get larger, but the female pattern is what it's associated with. Now, we speak of male and female patterns. This is male pattern baldness. So this is related to the testosterone in men. And not all men have it, but quite a few do. But this is the pattern of baldness, and it's associated with the hormone. Now, the balance of hormones, estrogen, testosterone, plays a very key role in normal sexual activity and prowess. The excess of female hormone estrogen in the male can lead to such things as gynecomastia, which is breast enlargement in men, and undescended testes, and short stature. These are all associated with extra estrogen in men. But women also have this male hair pattern in certain instances. That's an indication that the male hormone is a little overactive in the female. So this hair pattern is not limited to Caucasians, but we all have it, men, black and white, oriental, what have you. Now, these are spider veins too. Their size is small, very similar to the ones that I showed you in the thigh. But these are associated with these darker blue veins. You see these? And these veins lead into, actually the spider veins lead into these larger blue veins. And these are a prognostic of possible varicose veins. So these need to be attended to from a medical point of view. Treatment of these will be discussed a little later, but these are just the beginnings of the classification of varicose veins. Varicose veins are classified in accordance with a system that the American Venous Forum had decided upon in 1994. And that classification is primarily for physicians, but it's also helpful in the development of standardizing what we're looking at or what we're speaking of when we talk about varicose veins. It's called the CHEAP system, or CEAP system, which is based on, C is for clinical appearance, and the E is for the etiology or the cause of the condition, and A is the anatomic appearance of the vein, and P is for the pathophysiology associated. So this would be classified as a C1, almost a C2. Now, C0 is the beginning of the CHEAP system because they feel that there are 7 stages of varicose veins, with C0 being the non-symptomatic and no obvious appearance of varicose veins or spider veins. So that's C0. C1 is telangiectasia, which I'm showing you now, and the reticular veins. C2 is the appearance of varicose veins, which are these. Now, these may be perfectly asymptomatic, except perhaps for a little fatigue or minimal swelling at the end of the day if you have a long-standing occupation, such as a waitress, or even if you're sitting for a prolonged period, such as a bus driver or someone who sits all day. You build up hypertension in the vein system because they're not performing as they should. They're not bringing the blood back from the foot to the head, and I'll explain that a little later. Now, this is another appearance of varicose veins starting, and this is what we call C2, C3. Actually, this is the discoloration of the skin around here, which means that the blood is leaking through the veins and getting into the skin, depositing hemosiderin, which is a breakdown product of the red blood cell. And it's brown because of the iron in the hemosiderin. And over time, this condition makes the leg feel very firm. The skin feels firm, almost like wood, and we call it woody induration. And then of course, then we get more into the ulcers, which is C5. And we have, of course, various gradations from C0 to C6. But this is when we have the open ulcer. C5 is when the ulcer is like this, but it will heal on its own, or it may not require extensive medical professional care, but by elevating the legs, eliminating some of the drainage of the residual blood in the lower leg, and warm compresses, it may heal. Here, it's a little worse. You're getting the swelling in the leg, the discoloration, and the ulcer. So here we have what we call a C6. Now, looking at the circulatory system, we have veins that accompany all the arteries in the body, all starting off in the heart. The veins that we're talking about in this instance of the leg is the superficial greater saphenous vein here. And this runs all the way down to this area. Now, this is the greater saphenous, but so if there's a greater, then there must be a lesser saphenous too. Well, that's here. It goes to the back of the leg and down to the outside ankle area. Now, all the blood in the body starts from the foot, looking at this end of the body. It goes uphill to the heart. Now, the heart pumps the blood through the arteries, but it pumps it downhill, and it has a major pump that's propelling the blood. At the end of the arterial circulation, it goes into small vessels that we call capillaries, and the capillaries are joined at the other side of the flow by the veins. So that's the connection between the arteries and the veins. Now the blood begins the uphill journey. And from the head, of course, it's a downhill flow, but it's a lot easier. And from the hands and fingers, it's uphill, depending on what position your hand or arm is in. But in the legs, it's statistically significant that the veins and are subjected to this uphill requirement. So therefore, there are 5 to 6 valves in the veins between the groin and the ankle, in the femoral vein and in the saphenous vein, a total of about 5 to 6 valves. The valves allow an upward motion each time the calf muscle propels, and the calf muscle is considered to be the venous pump. That's what circulates the blood, in addition to a small amount of pressure from the flow from the capillaries in the foot upwards, driven by the heart. The the body contains about 1.5 gallons of blood, or 9 to 10 pints in the average man who is 6 foot and weighs about 200 pounds. Now, this is variable. It could be between 10 and 12 pints of blood, or 5 liters. And in the woman, it's a little less because of a smaller size. A 5 foot tall female weighing about 165 pounds, you have a little less blood, let's say 9 pints. And of course, in an infant, in a child, everything is based on weight. Now that means that the blood must weigh something when it gets to the lower part of the leg. And we measure the weight of the blood in terms of columns of mercury. And the weight, as you can see down here, it's roughly 40 milliliters of 40 milligrams of mercury weight. And up at the arm, it's a little less. And of course, with the negative flow here, it's 0 from the head, it's minus 10, but the blood all has to get back to the heart. And so with the weight of the blood being pushed up, there must be some system to do that. That system happens to be the calf muscle of the leg. It's called the venous pump. And as you can see in a static situation, the weight of the column of blood can be up to 90 millimeters of mercury at the foot and 40 at the mid-calf level. When you walk, you flex that calf muscle, pushing the blood up. And that's the pumping effect. It reduces by half the weight of the column of blood. So in a situation where we have varicose veins, the blood collects in the lower part of the leg and makes the, it extravasate, it comes out of the vein itself in the form of plasma, and over time the blood cells, which we saw break down and deposit in the skin. Now the valves of the vein are these little outpouchings that are very, very thin, paper thin. And when the valves open, when you walk or when you compress the vein from the foot, it pushes the blood up. But at the termination of that compression, gravity pulls it back down, the blood. The valves are supposed to close. And that is the normal operation of these veins. However, in the healthy vein, this is the way it functions. But in the diseased vein, we see the valves just do not work for various reasons. The vein may be wider, the diameter may be increased because of the weight pulling the valves apart, or the valves fail because of the increased weight on the valves. So the blood collects in the lower part of the leg. Now, more than 1 million people in the US suffer from leg ulcers, which is about 1%. And 70 to 90% of the ulcers in the leg are below the knee, caused by the venous failure to function properly. More than 50% of the ulcers below the knee in any patient happens to be secondary to varicose veins. And of course, because of these difficulties with blood collection in the lower leg, there's pain, mobility limitations, and other consequences. Ulcers have been associated with increased rates of depression and substantial decreases in the patient's quality of life. Now, veins, varicose veins, have been in existence for a very long time. The first medical recording was found in the papers of, well, we don't use papers at this time, it was papyrus writings in 1550 BC. And that was a long time ago, as you know, and Hippocrates, who was supposed to be the father of medicine, advised against surgical management of this disease. Historically, we have found that the varicose vein treatment started basically as non-invasive. So it was at least non-surgical, but we were treated with various potions, lotions, treating the ulcers, because this is the extreme condition that we see. And these veins were treated conservatively, as we would call it today. Back in 1963, a doctor in Ireland, George Fegan, he changed the system of treatment. The system of treatment at that time had been the patient standing, and we could treat just the veins that we could see just with the naked eye. And so that would mean the veins that we showed you before as varicose veins, which usually are in the lower leg. You couldn't see what was up here. But with the attempts at treating the veins in a standing position using the drugs such as sotradecol and polydocanol, these are drugs that originally derived in places where there were lots of varicose veins, and they were using every conceivable method of treatment to affect the inner lining of the vein to make the vein close. And these medications came primarily from England and Ireland. And Dr. Fegan was at Trinity College in Dublin. And at that time, he was using this system, the standard standing and injecting. But he decided to elevate the leg and try to empty the vein. So we have this Trendelenburg position in which the foot is elevated and the head is lowered just a little so as to drive the blood back towards the heart. He thought that by emptying the vein, the medication could be more effective in reaching the vein itself, because blood tends to dilute the effectiveness of any drug that you put in it. So to try to empty the vein made it much easier to affect the endothelium, or the lining of the vein, which needed to be disturbed in order to make it scar. And by scarring, the vein would close and you would have treated the affected area. This was the seminal paper at that time, and most, well, I would say a great number of surgeons came to Ireland to watch Dr. Fegan use this procedure. Now, Vein Clinics of America was the #1 vein treatment company in the US, starting in about 1988. And they used this Fegan technique. They found that this was effective up to a point. And since that time, we have gone a little further. Now here, again, is that brown induration area that we mentioned before, with the blood collecting in the leg itself. Here again, another picture of the same thing without the darkness that we saw in the last slide, but the swelling and the beginning breakdown of the skin here. So this again gets into the CHEAP system, the CEAP system, which, as I mentioned before, was for doctors to speak in the same terms of what we're talking about when we look at a varicose vein patient. And for charging purposes, if the doctor needs to get paid for his services, we now go by what we call the CPT system of billing. So the doctors have to describe so that they can be paid appropriately for whatever they're doing. Now, if we look at the circulatory system total, heart and lung, heart, lungs, arteries, and veins, we see the heart is the big muscle that makes everything happen. The left ventricle pumps the blood out through the aorta. This is the return. This is the aorta here. It sends the blood down through the entire body. Head goes to the head and then down to the foot, as we can see here. And then it transfers over in the capillaries to the veins, and the return trip to the right atrium. This is the part of the upper right chamber of the heart. The blood is then, when the heart contracts, it squeezes and relaxes. When the heart relaxes, it sucks the blood into the ventricle, and when it squeezes again, it sends it out through the pulmonary vein. Pulmonary artery. This blue color is used when we speak of blood flowing away from the heart. So I'm sorry, the blood flowing away from the heart is called an artery, through an artery, although it happens to be deoxygenated blood, which is venous blood. So it's blue here, but the name, the terminology is that of an artery. So it's a pulmonary artery that goes up to the lungs. The lungs saturated with oxygen, and then send it back to the heart through the pulmonary veins. Blood going into the heart is considered traveling through a vein, even though it's arterial blood. Because of its going to the heart, it's called a vein. So it empties in through the atrium, the left atrium, pumped down into the ventricle, and then out the aorta. So this is the complete circulation of the blood vascular system. So when we talk about venous disease, everything here fits into that category. And that's what we're talking about. Now, the treatment of varicose veins is a good question, and the treatment has changed over the years. And the initial treatment was with injection therapy, which didn't seem to work. So despite Hippocrates' admonition about do no surgery, vein stripping was instituted. Now, vein stripping meant that we strip the vein. Let me go back here and show you one more thing. Here, when we strip the vein, we take the saphenous vein from the femoral vein up at the groin, all the way down to the foot. Now, by doing this, this is not shown on the diagram here, but the greater saphenous vein communicates with the femoral vein, so that the blood in this small vein, which is the saphenous, enters the femoral vein at all different locations through what we call perforating veins. And if that were not the case, we could not sit down and cross our legs without our feet swelling, because the blood would be interrupted. It could not flow because of the kink in the vein. So the connections are all the way up. So when you strip this vein, you strip it away from these communicating veins that are in here. And when you do that, there are roughly 90 communicating veins between the groin and the ankle. So when you strip it away from the communicating veins, that leaves these communicators bleeding. We wrap the leg in a bandage to compress the vein and stop the bleeding. But over time, as we get up and walk, and over perhaps a year and a half, the veins, the communicating veins, open up. This is called recanalization. So they open again, and once they open, they begin to grow. And you have a multiple return of veins. So you had one that you took out and you have 90 possibilities of growing back. So vein stripping has turned out not to be very good in terms of a treatment. And the question is, does it work? Well, it doesn't work. Very few surgeons at this point in time do vein stripping. The current forms of treatment are sclerotherapy, which is injection of medication into the vein with the vein in a relatively empty position. Small spider veins are always treated with sclerotherapy, and it doesn't really matter whether the person is standing or sitting, usually because the vein is so small that you can close it with pressure just when you apply the medication. The next form of, well, this sclerotherapy is limited in terms of the size of the vein. We cannot use it in the saphenous vein. This is primarily and almost exclusively for spider veins and telangiectasia. The next form of treatment is a progression. We've learned a few new things. We use radiofrequency ablation. This is called a closure procedure. And the names don't matter, but the idea is that we put an electrode into the vein through ultrasound guidance. So we look at the leg and we can identify the vein, and we put a small cannula into the vein, and through it, we put a long catheter that's equipped with the radiofrequency at the end or a certain location within that tube. And we apply heat to the vein because we do elevate the leg at the time of the heat application. And this is done to scar the inner lining or the endothelium of the vein as we extract the catheter. Now this form of treatment is limited to treatment above the knee, from the knee towards the groin, because the vein has to be straight, cannot be curled or twisted for this relatively rigid instrument to be inserted in the vein. Now, the same applies with laser. Laser can be applied the same as this. It's the laser is introduced through a small cannula introduced into the vein, the same as here. The only difference is the source of heat. With radiation, with a laser, we are dealing with roughly 1,000 degrees of Fahrenheit, and this is 180. So the difference is significant. And this causes increased bruising, breakdown of the blood vessel, and there may be more scarring, and you have to be pretty quick in removing it, the catheter. Venous seal and foam sclerotherapy. These are different technologies using chemicals. Again, with the foam sclerotherapy, this is polydocanol foam. So it's the medication is mixed with oxygen and nitrogen in small quantities and made to bubble within the vein. The vein, again, is emptied by elevating the leg. The medication is introduced at the lower part of the around the knee and carried up to, but not into the femoral vein. This is compression that can prevent that. And it's felt that with the foam therapy, the medication becomes more intimately in contact with the endothelium, and the effect of scarring is increased. Now that is pretty much the story of varicose veins and treatment. And all patients who are treated for varicose veins need to be fitted with compression hose. These are stockings that provide a measured pressure to the vein as it is healing. And if you are going to continue in your standing occupation or even long sitting, because this compression, as you see by the diagram that I showed you with the weight of the blood in the vein, the compression stocking must overcome that weight. So they must measure compression of at least 30 to 40 millimeters of mercury in compression of the vein. Now, wearing the stocking over time and a failure to walk makes the stocking become very tight and uncomfortable. So if you are fitted with compression hose, you have to walk to introduce that calf muscle pump to circulate the blood back to the heart and prevent it from trying to collect again in the lower leg. Because as the leg swells, the stockings become tighter and very uncomfortable. So now, are there any questions? Anybody?
Yes, I have a question, Doctor.
Yes.
I'm Mary Ellen Brooks.
Mhm.
And my question is, I've been diagnosed with PAD. And I wear the stockings. I see little, areas that I can see a dark vein in, but I don't have any pain from that, but I feel the heaviness sometimes. And is PAD, that's in the realm of the varicose veins also?
No.
Okay.
I don't. That's more edema, and it's well. Apparently, the fluid has crept through the vein itself and into the tissues, and the swelling occurs.
Okay.
And the compression is necessary, but you can apply below knee stockings of the same compression, 40 millimeters of mercury, 30 to 40. You can wear those when you're going to be standing or sitting for prolonged periods.
But one doesn't necessarily lead to the other, is my question.
No.
Okay.
Yeah, Dr. Ivey, thank you so much for that presentation. Can varicose veins lead to blood clots?
Yes, those are some of the complications of varicose veins. Usually the clotting in the greater saphenous vein or superficial vein is can be managed with just heat and elevation. It does not usually transfer to the femoral vein, but it can be clotting within the in the greater saphenous vein. And of course, it causes pain, discomfort, and you should see your doctor, and he will prescribe the appropriate treatment for it. But the primary source of clots to the heart from the veins come from the femoral vein, which is the deep vein, which requires an altogether different form of treatment. Anticoagulants, in certain instances, we do vena cava ligation. So the major blood vessel in the body, which is connected to the femoral. The femoral enters into the iliacs and then into the inferior vena cava, and that's where a filter can sometimes be placed to prevent clot just reaching the heart and lungs.
What are the other complications of varicose veins?
Well, the basic complications are the swelling of the leg, thrombophlebitis, which is an inflammation of the vein itself. That's the leg gets red, hot, very sore, difficult to walk, and swollen, in which case you need to be hospitalized or at least treated with the leg elevation moist compresses, heat compresses, and antibiotics. But your doctor would make that decision about that. And the other complication, of course, is ulcers. What I've shown you basically are the complications of varicose veins. Now, in regard to who gets these veins, women get them almost twice as often as men. And women, because of the estrogen effect that they have the increased propensity to develop varicose veins. And with pregnancy, that is another source, because here again, the increase in estrogen and the weight of the baby as it grows in the uterus applies compression to the vein proximal, in the proximal location in the abdomen where the iliacs are located. So you have obstruction of the blood flow and increased possibility of varicose veins. And also with standing occupations, family history plays a role. If you've had parents or relatives that have varicose veins, you might be well on your way. Obesity, heavy weight gain, because the more weight you gain, the more blood you require in your body for circulation, and that increases the weight of the blood going in the legs, and so you are prone to that condition. Injury, trauma. I had a patient come to me with he was a Marine, he was a tough guy, well built, and he had this cluster of varicose veins in his mid-thigh. And he said that he had been tackled when he was playing football some years earlier. And apparently the vein valves were broken and he developed that. So injury can cause the varicose veins also.
The person mentioned PAD. What is PAD?
That's pedal edema, essentially. Swelling of the leg before, from the knee down.
Right, and so PAD actually refers to peripheral artery disease, which is a little different from what you're talking about, isn't it?
Well, peripheral artery disease is not well, peripheral artery disease essentially means that it's claudication. The symptoms are pain when you walk, and that's not related to varicose veins at all. That's disease of the artery that is aggravated by ambulation, because the blood requirement of the muscles of the calf the supply does not meet the demand, and it causes the pain in the calf muscle with walking, but that's arterial disease.
Okay, Dr. Ivey, I have a question about groups of people that are most prone to varicose vein disease. And as you say, women have twice the incidence of men. And I always thought that varicose vein disease was something that white people had that were more prone to than blacks. Looking at an article on the internet that says that Hispanic women are the most prone at 26% suffering varicose veins, and then non Hispanic white at 24%, followed by African American women of 20%. But then I'm a little puzzled about Asian women because they're at 18.7%. And so they have the lowest incident, although they all, it's doesn't appear to be melanin related uh, because Asian women are, for the most part, low melanin, but they also have a low rate of varicose vein disease. So is there any connection? It doesn't appear to be any connection between melanin and varicose veins. Am I looking at that correctly?
No, there's no connection. The size of the patient, the Asians tend to be smaller, so there's less weight involved. Unless they become obese, as many of the Latino perhaps may become. So the more weight you have relative to your height, the greater the strain on the venous system. So it's more physiologic rather than melanin related.
I noticed that when you show the chart of average blood measurements for men and women, that for the height and weight, they were all in the overweight group. And I'm wondering if that's become the new standard for measurement rather than normal BMI. But when you're looking at overweight people, they generally have high blood sugar levels. And is that high blood sugar levels that compromise venous health?
High blood sugar levels tend to affect the veins themselves, the effect on the valves, and the actual physiologic changes that occur with diabetes leads to that. It's something related to the disease process rather than it being primarily venous related. It's other factors can cause this varicose veins, but it's not purely vein related. It's related to other secondary causes, and diabetes happens to be one of them. Increased blood sugar, sometimes basically hypertension can also cause it. Because with hypertension, you have increase in compression of the arteries and failure to return the blood, particularly to the kidney. And this creates a problem with your overall circulation. But all things are intertwined here. So disease processes other than purely anatomic vein problem affects the overall varicose vein diagnosis.
Dr. Ivey, thank you very much. This is the other John. I had a couple of questions. One, you several times you mentioned a cannula. Can you describe that for me?
The cannula is any sort of wire or instrument that can be small enough to be introduced into the vein can be called a cannula. Okay. But this is a small wire that is covered in certain areas to prevent the electrical or the radio frequency from being distributed beyond where it's intended to be distributed, is what we're talking about. And these are very small wire because you can't use much more than an 18 gauge needle to insert these things. So the wire has to fit in that capacity. So it's relatively small.
Okay, thank you. And how does spider veins and varicose veins relate with neuropathy?
Well, neuropathy is a totally different situation. That has to do, by its name, it's related to the nerve. Now, if the peripheral neuropathy can be related to several other things, but it has no relationship to varicose veins.
Okay, my eldest stepbrother passed away last year. He drove a Uber and a Lyft constantly. I mean, he was driving, the whole time, and I don't think he was standing up very much. He had blood clots, and the clot broke off and went to his heart, and he passed away. So your point about standing and walking is very well taken. I started walking a couple of years ago because I couldn't swim, but now I'm back to swimming. So those exercises help keep the blood flowing through your veins and arteries. And also I'm taking yoga, which also has some definite advantages for putting the legs and arms up above the heart, and the blood flow back into the body. Do you have any comments about yoga? Is that helpful?
Yes, well, yoga is good. I had a patient who came in with these distended veins in her forehead and in her face. And I asked her about that, and she was a yoga advocate. She was standing on her head a lot. Provided you don't stand on your head, yoga is good in terms of reversing the pull of gravity on the veins. But I would not advise a lot of head standing.
I definitely don't do that. No worries.
Could swimming be better than walking since you don't have the fight gravity on the blood return?
Well, no, walking can't be replaced. It doesn't, it's not the same because the pull of gravity in swimming is not really there. So that's one of the best things for people who have poor circulation from a venous point of view is to swim. But walking is what allows the calf muscle to contract and relax. And that's really the venous pump for the veins. The heart has a limited value in terms of pumping the venous blood back. You'll notice that when you cut yourself, if you cut an artery, the blood spurts intermittently. If you cut a vein, it just oozes out. And there's a difference there. And so for venous circulation, we really need the calf muscle. People who have below knee amputations or things like that, they have very difficult times with the venous circulation. And it's related to the absence of that ability to walk, or at least exercise the muscle, even while you're sitting, or if you can just stand and raise yourself on your toes and down, up and down, that's better than nothing. The veins, I failed to mention, is the reservoir for blood. The blood, if I say that's 1.5 gallons of blood in the body, 1 gallon is in the veins and 0.5 gallon is in the arteries. So the veins are very distensible, and they can hold reservoirs of blood. in the system. That's why when one goes into blood loss shock, we tend to elevate the legs to empty those reservoirs to allow for better circulation. So the veins contain extra blood so that you could lose a pint of blood and still not be affected in terms of passing out or any kind of real symptom, because the veins provide the extra blood that is in reserve. It also, of course, the circulatory system, the veins in particular, control your blood temperature, your body temperature. And that's very key. You notice that when you shiver, the muscles are in contraction, the arteries and the veins contract. The veins have very little muscle, but the arteries do. And the shivering provides more evidence of the fact that the body temperature is lowering.
Oh, good. Thank you very much, Doctor. Thank you for your presentation. Yes, please. Hello.
A couple of are ahead of you. Elizabeth Deutsch and Sylvia Davis.
Yes.
Hello.
Okay. Thank you, Dr. Ivey. Very comprehensive presentation. Got a question regarding, I am a walker, and I caught a Charlie horse cramp in the calf. And then when I noticed after that, I had the little varicose vein. Is there any correlation to that type of trauma and the generation of those types of veins?
That may have been coincident. It may have been that you had the vein before, but you didn't notice it until you got the Charlie horse. It's hard to say, but the only way that we can really determine whether or not you have a varicose vein is by use of ultrasound. We have the modern techniques now for diagnosing the condition of the vein itself by looking at it through the skin without any invasive manipulation. We can actually see the blood flow in the vein, and we can determine if the valves are functioning or not. So when you say you see a vein, whether or not it's a varicose vein or just a bulge in the vein is difficult to say just by looking at it through with the naked eye.
Oh, I see.
But if you're concerned, I would suggest you follow up with the physician.
Okay, and the second question is, what about massaging in that particular area in terms of, does that help in terms of giving any kind of relief to the veins in the calf?
It certainly does. Massaging the calf muscle promotes venous flow. It's towards your heart, So massaging is good for that condition.
Okay, thank you.
Mm-hmm.
Elizabeth Dorff, you're next.
Yes. Good morning again, everyone. Thank you, Dr. Ivey. This is such a wonderful and very informative presentation. I am Elizabeth, and my question is around aspirin. I noticed that my mother, who's 95 years old, as well as other siblings that's past 60, the doctor recommended they take aspirin. But I noticed that sometimes bruises are found on the body after taking aspirin. And I'd like to know that these bruises, are they reflected? Are they connected to the veins reaction or what?
No, aspirin is a medication that tends to promote the failure of clotting in the blood. So when they tell you to take aspirin, it's primarily to dilute the blood, or we won't call it an anticoagulant as such, but it tends to slow down the clotting of the vein, of the artery, of the blood. And the idea is to prevent clot formation strokes, things like that, which we want to avoid in certain patients. And now, so that has a lot to do with bruising in that instance, because it does prevent clotting to some degree, and the blood may extravasate through the vein and cause this bruising just with slight trauma, like you brush your hand or something and you hit it and the bruise appears. That's because of the increased likelihood of lack of clotting mechanisms within the blood system. But it doesn't have anything to do with varicose veins.
Thank you.
Mm-hmm.
You finished with your question, Elizabeth? Because Dr. Atto is next.
Yes, Dr. Atta.
Okay, yes. Yeah, I just forgot what somebody has asked me. This blood thinning.
Yes.
Sometimes they give you some medicine and they tell you that it's for blood thinning. How does it affect the veins? These blood thinners.
The blood thinning means that you fail to clot. They remove some of the clotting factors in the vein, in the blood. As a result, the minor trauma to the veins or arteries may cause blood to extravasate, to go outside of the vein. So it's the vein wall that allows the blood to go through, but the vein wall is not necessarily affected by the clotting material, anti-clotting medication as such. It's that the fact that when the blood gets out there, at least through the opening areas within the vein from trauma, blood cells may get out and they won't clot, and you will see the bruise.
Thank you. Thank you very much.
Yes. Anyone else?
Let me ask you a question, Dr. Ivey. Men have varicose veins, as you mentioned. You said that we have estrogen. But do you think that men have as much varicose veins as women, but we just don't pay attention to it because our cosmetic interest is less?
I think that's particularly true with spider veins. Spider veins, women are very fastidious about wearing shorts and bathing suits and things like that expose their legs, and they pick these things up. Men, on the other hand, because of several factors. One, there's less fat in the average male who's not overweight than the average female who is a normal weight. The fat sort of separates the vein from the skin, so you don't see it as much. Not that it's not there, but you don't see it. In a man, you can see the veins almost because the skin is almost
Financial
right
planning is looking beyond today's horizon, and it's charting the route to get there.
And
as a Citigold client, a dedicated team.
As a result, the men may show their veins more frequently than women, but they don't have varicose veins. So you see the veins in the man's leg, but the man doesn't have varicose veins. It's just that you see them. Whereas a woman, because of the fat that separates the skin from the vein, you won't see it usually unless there is a defect in the vein. So you see the varicosity in the woman. So I don't think that the relationship, the numbers that we have given in terms of frequency of male, female are incorrect. Anything else, Dr. Callender? I can't hear you.
Yeah. No, thank you, but anybody else out there have any questions? No.
Yeah, this is John Tatum, the other John that's in the hospital.
Yes.
How
Hope you
you
feel
doing?
better.
Yeah, good presentation. I wanted to ask a couple of questions. I noticed that as far as the elderly white women, you can see their veins better because of their light skin. And the other question is, what about blood clots?
Well, the circulatory system is designed to be in constant motion. So the blood is always moving. As long as the blood is moving and you have a normal blood clotting capability, then you shouldn't have clots. If the blood stagnates, as in varicose veins with long standing, you have the propensity to develop blood clots because the blood is not circulating, it's standing. It's very slow in motion. And as the leg swells, that means that there's more blood standing in that extremity than is otherwise normal. And the pressure created by the swelling compresses the vein even more to make the blood flow down more. So blood clotting and varicose veins, one can lead to the other. Varicose vein. In other words, the varicose vein stagnation can lead to clotting in the venous system. Does that answer your question, Mr. Tatum?
Yes, it did.
Okay.
Yeah, that answered my question. The only other question was people who have lighter skin. Do that? Is it their varicose veins show up clearer?
Well, generally speaking, white people or Caucasians have more transparency of the skin because of the lack of melanin. And on the reverse side of that, darker patients have a more difficult time being seen with veins. That's why in the hospital, many times white doctors have a difficult time drawing black person's blood. They say they can't see the vein. Well, we have to know where the veins are. And because of the complexion or the lack of melanin, it's easier to see the vein, but that doesn't have a lot to do with the presence of varicosities. Varicosities still are based on the valve function within the vein itself. Now, even though you can see it, as I mentioned before with Dr. Callender's question, because of the lack of body fat, the veins in a man are more visible, be they black or white, than in a female, because of the proximity of the vein to the skin itself, as opposed to being separated by fat. The veins are just right beneath the skin. And if in a lean male or even a lean female, you can see the veins more prominently, but that doesn't mean that they are varicose, the fact that you can see them. Does that answer your question?
Thank you, and yes, that does.
Mm-hmm.
Thank you.
You're welcome.
Mr. Buchanan?
Yes, thank you again, Dr. Ivey. Lately, I've seen a lot of advertisements on TV for vein treatments. Is there any, do you know about the cost or the type of treatments that I've heard about laser, varicose vein treatments? Should we pay any attention to those advertisements?
Excuse me, that's a good question. I think so many people, physicians and companies, before veins were treated primarily by surgeons, even though they were being injected. Now veins are treated by dermatologists, cardiologists. I conducted a class out at Suburban Hospital on vein treatment with a group of cardiologists, because the technique now does not necessarily involve a scalpel. We don't have to operate, but it is in our best interest to have someone who.
Please pick up on line 8 for Dr. Lobrano, returning your page.
Mr. Tatum, I think you need to mute.
Yeah, I have a host. Host, would you mute me, please?
I think the various organizations are advertising different methods of treatment, but basically, as I described before, we have either radiofrequency treatment, laser treatment, or sclerotherapy. And the sclerotherapy of choice is the foam sclerotherapy. So any organization that provides any of these three is within the current state of the art. Now, with all these treatments, these three that I've named, we have to use ultrasound to determine where and when we put the medication in or we apply the heat source. And of course, the newest thing has another name, but it's a foam sclerotherapy using 1% polydocanol. And the generic name doesn't much matter. The idea is that this is what you're using, a foam sclerotherapy. You have to find out what they're using. How is this working? Is it laser? Is it radiofrequency? Or is it foam therapy? As I said before, we rarely use surgery other than what we call phlebectomy. In other words, if there's a small bulging vein, we can take that vein out through a surgical incision without disturbing the entire saphenous vein. This is a branch that has become enlarged, tortuous, possibly painful. We can excise that using this technique that we call phlebectomy. Any other questions?
Yes, Dr. Ivey, this is Sylvia again. The discussion just brought another question to my head regarding varicose veins and hydration of the body. What's the impact in terms of keeping the body hydrated and its impact on varicose veins, or does it help reduce varicose veins?
Well, hydration is always good, except if you're in heart failure. We try to keep people relatively dry, but in veins, it certainly helps with the flow. If you don't have a swollen leg or edema, because many times we use diuretics when patients have edema, swelling of the leg secondary to increased collection of fluid. So there are two sides of the coin. If you have a normal circulation, intake of fluid is desired, high intake. It affects the kidneys, it affects everything. If, on the other hand, you cannot handle the fluid properly, then we have to limit the intake of fluid. Any other questions?
Thank you.
I have just one question. I know Dr. Callender had mentioned before. What is that tool or apparatus that you use to put on the stockings? There's something that makes it easy for someone to put on their own stockings. Those
Well, we have what we call a caddy. and it's a metal contraption that's designed for you to thread the stocking over the instrument and then slip your foot down into the open stocking, which makes it a lot easier for people who have arthritic hands or weakness in the hands and have a difficult time getting these stockings on. Now, the particular manufacturers of these stockings will provide various forms of this mechanism to assist you in putting the stockings on. I know Medi, M-E-D-I, as one manufacturer, provides this sort of thing for application of the stocking. Jobst, on the other hand, and both of these are German companies, provides another form of this. But generally speaking, you cannot get it at the drugstore. It has to be a medical supply house, or your doctor can order it for you.
Thank you.
Yes. Any other questions?
That was very helpful for my wife when she had her varicose vein problem.
Yes, Medi can provide them, and if you let me know, I can order one for you.
Okay, I was inquiring for my sister-in-law because she has arthritic hands, and she was saying she can't put them on. She has to get a neighbor or somebody to help her put them on. So
I cannot tell you the cost. I don't know the cost, but I can certainly check with the company, or you can contact the company and ask them, or probably go online.
yeah, I was thinking about going online. That's MEDIC.
MEDI. 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 And Jobst is JOBST. JOB is in boy, ST.
Thank you.
Yes.
Dr. Ivey, in your experience, are people with fatter calves more likely to have varicose veins?
No, I have not found that to be the case. The size of the calf doesn't, it portends really to be less likely to have varicose veins. If it's muscle that's causing the weight or the size of the calf, if it's just pure fat, then that adds to the weight of the patient and increased blood volume and increased weight of the blood in the vein itself. So that's why obesity is one of the contributors to varicose veins.
Well, if there are no more questions, we are blessed to have Dr. Ivey with us today to give us the advantages of somebody who specifically worked with venous disease since 1988.
Yeah.
Yeah. So
the thing is that they're changing every so often. New techniques are coming in, but medicine is an evolving specialty, so that's to be expected. We are trying to improve all the time.
Yeah. Well, we appreciate the fact that you brought your expertise to us, and we can't thank you enough. Any other announcements before we close? If not, Carol, anything else going on? Any reports back from your the event that you had 2 weeks ago? You want to tell us anything about that?
Oh, the event that we had, it was nice. Missed you. Okay. And just keeping prayers for John, and that he gets in a nice rehab.
How's the fish fry since your father-in-law?
Oh, the fish fry, my daughter-in-law's